Hello and welcome. My name is Dr. Hannah Rosa. I'm a GP working in the northeast of England and a member of the GPnotebook education team. In 2024, the British Thoracic Society, NICE and SIGN joined together with the aim of improving the lives for people with asthma. And in November last year, they published their joint guideline on asthma diagnosis, monitoring and chronic management. Want to find out what's changed? Well, I'll be going through the guideline in detail over 2 podcasts. In part 1 today, we will cover diagnosis and the pharmacological management in people aged 12 and over. In part 2, we will cover pharmacological treatment in children aged 11 and under, monitoring asthma control and self-management. At the end of both podcasts, I also have a quick quiz for you. First though, I'd like to start by discussing when we should suspect asthma. In the clinical history, the key symptoms to watch out for are wheeze, noisy breathing, cough, breathlessness and chest tightness, and then to inquire whether these symptoms vary. For example, are they worse at night or early in the morning, or are they seasonal? The next thing to ask is whether these symptoms have any triggers, such as upper respiratory tract infections, pollen, dust, animals, anti-inflammatory painkillers, cold exposure, or exercise. The other group that we need to be aware of here is those with occupational asthma. In people with adult onset asthma, poorly controlled established asthma, or who have the reappearance of childhood asthma, we should check for a possible occupational component by asking if their symptoms are the same, better or worse on days away from work. If we then suspect occupational asthma, we should refer them to an occupational asthma specialist. Finally, in the history, we should always check if there is any personal or family history of asthma or hay fever. When carrying out an examination, remember that if it is completely normal, then it doesn't rule asthma out. Those patients with a suggestive clinical history should be coded as having suspected asthma. To confirm the diagnosis, the patient also needs to have had a supporting objective test. So, on to diagnosis. To diagnose asthma, there are some big changes within the new guideline. Previously, in the NICE 2017 guideline, Step 1 was spirometry for everyone from the age of 5. However, around 50% of all cases of asthma have eosinophilic features. The main way of detecting the inflammation caused by eosinophils is through blood and fractional exhaled nitric oxide, otherwise known as the FeNO test. So, Step 1 in the 2024 guideline for people aged over 16 with a history suggestive of asthma is to measure the blood eosinophil count or the FeNO level. If the eosinophil count is above the laboratory reference or the FeNO level is 50 ppb or more, then asthma can be diagnosed. This is headline-grabbing news. Just to emphasise this point, now, if a patient has a history suggestive of asthma, then we can potentially confirm the diagnosis with just a blood test. This is a huge change from the previous 2017 NICE guideline, where a blood eosinophil count was in the list of tests that we should not be offering. If asthma is not confirmed by the eosinophil count or FeNO level, then the next step is to measure bronchodilator reversibility with spirometry. To diagnose asthma, the FEV1 should increase by 12% or more and by 200 millilitres or more from the pre-bronchodilator measurement, or if the FEV1 increase is 10% or more of the predicted normal FEV1. As an alternative to step 2, if spirometry is not available or it is delayed, then we can ask our patients to measure peak expiratory flow twice a day for 2 weeks. On the Asthma and Lung UK website, they have peak flow diaries which can be freely downloaded. The key points to highlight to patients are that they should record their peak flow every morning and evening, for example before they go to bed, for 2 weeks, and that each time they do their peak flow they should do it 3 times and record the highest of the 3 results in their diary. The new guideline then informs us that we can diagnose asthma if the peak expiratory flow variability, expressed as an amplitude percentage mean, is 20% or more. Now, before you start looking back through old maths books trying to work out how to calculate amplitude percentage mean, don't panic, as the Asthma and Lung UK website has a peak flow variability calculator, and that will do this for you. I've put the links to both of these resources in the show notes. The final step, if asthma is not confirmed by eosinophil count, FeNO, bronchodilator reversibility or peak expiratory flow variability, but still suspected on clinical grounds, is to refer to secondary care for a bronchial challenge test. Asthma can then be diagnosed if bronchial hyperresponsiveness is present. A bronchial challenge test is a test to measure airway responsiveness. It is performed by giving small increments of a bronchoconstrictor and measuring the FEV1 after each dose until it falls by a predetermined amount, usually 20% from baseline. So, that covers all the steps involved in diagnosing asthma in people aged 16 and over. But what about in children? Well, to diagnose asthma in children aged 5 to 16 with a history suggesting asthma, step 1 is to measure the FeNO level, and a diagnosis can be made if it is 35 ppb or more. If the FeNO level is not raised, or if FeNO testing is not available, step 2 is to measure bronchodilator reversibility with spirometry. A diagnosis of asthma can then be made if the FEV1 increases by 12% or more from baseline, or if the FEV1 increases 10% or more of the predicted normal FEV1. If spirometry is not available or it is delayed, step 3 is to measure peak expiratory flow twice daily for 2 weeks. We can then diagnose asthma if the peak expiratory flow variability, expressed again as amplitude percentage mean, is 20% or more. If asthma is not confirmed by FeNO testing, bronchodilator reversibility, or peak expiratory flow variability, but still suspected on clinical grounds, step 4 is to either perform skin prick testing to house dust mite or to measure total IgE level and blood eosinophil count. Asthma can then be excluded if there is no evidence of sensitization to house dust mite on skin prick testing, or if the total serum IgE is not raised. We can diagnose asthma if there is evidence to sensitization or a raised total IgE level and the eosinophil count is more than 0.5 times 10 to the power 9 per litre. Again, this is a huge change, as previously none of these tests in step 4 were seen as ways of diagnosing asthma. If there is still doubt about the diagnosis, then the guideline advises that we refer to a paediatric specialist. This then leaves one age group, the under 5s. Diagnosing asthma in these children is challenging because it is difficult to do the tests and there are no good reference standards. For children under 5 with suspected asthma, we are advised to treat with a regular inhaled corticosteroid and a short-acting beta-2 agonist as needed. Then we need to review these patients on a regular basis. If they still have symptoms when they reach 5 years, then we can attempt objective tests. If a child is unable to perform these tests when they are age 5, then we are advised to try doing the tests again every 6 to 12 months until satisfactory results are obtained, or to refer for a specialist assessment if the child's asthma is not responding to treatment. A new recommendation in the 2024 guideline that we need to be aware of is that we should also refer to a specialist respiratory paediatrician any preschool child who has had an admission to hospital or 2 or more admissions to an emergency department with wheeze in a 12-month period. As a final note, when it comes to testing, we should be aware that spirometry and FeNO levels can be affected by the use of inhaled corticosteroids, making the tests more likely to be normal. Now, on to treatment. Here, the big headline news is that we are advised not to prescribe a short-acting beta-2 agonist inhaler or SABA inhaler to people of any age with asthma without an inhaler containing a corticosteroid. So, no patients with asthma should just have a salbutamol or a terbutaline inhaler alone. The second massive change is that for patients with newly diagnosed asthma, age 12 and over, the first step is to offer them AIR therapy to be taken as needed. If, like me, you've never heard of AIR or AIR therapy, then it stands for anti-inflammatory reliever therapy. An anti-inflammatory reliever is a combination inhaler which contains a steroid to treat the inflammation in the airways and formoterol, a reliever medication which quickly opens up the airways. This means that patients aged 12 and over with newly diagnosed asthma should no longer have separate reliever and steroid inhalers. The latest guideline has made this change as patients on AIR therapy have been shown to have a reduction in severe asthma exacerbations compared with those using separate steroid and SABA inhalers. However, if patients are highly symptomatic or they've had severe exacerbations, then they should be offered a low-dose MART inhaler. MART standing for Maintenance and Reliever Therapy. This again involves using a combination inhaler with a corticosteroid and formoterol, but this time using it regularly for maintenance therapy and also extra doses as required for symptom relief. Options for AIR therapy or MART therapy in my local formulary are Duoresp Spiromax, Fobumix Easyhaler, Symbicort Turbohaler and Foster Nexthaler. The next step for patients whose asthma is not controlled on low-dose MART is to increase to moderate-dose MART. At this point, you may be wondering what strength or how many puffs of an inhaler constitutes a low or a moderate dose. Well, in the NICE guideline online, they have provided a link to a document which will guide you through the different types of inhaled corticosteroids available and the usage needed for low, moderate and high doses. I've also put a link to this in the show notes. If asthma still isn't controlled using moderate dose MART, then we are advised to check the FeNO level, if available, and a blood eosinophil count. If either of these are raised, then we should refer the patient to a specialist in asthma care. I'd just like to take a step away from the treatment pathway here to emphasise this point. In patients with asthma who are receiving and adhering to treatment with moderate dose inhaled corticosteroids, who have a persistently high FeNO level, especially if they are symptomatic, then they may be at high risk of exacerbations. Similarly, an article in Thorax stated that it should be regarded as a red flag for future asthma attacks if an asthmatic patient had an incidental raised blood eosinophil count. It's also worth remembering that some patients have steroid-resistant asthma, which doesn't even respond significantly to high doses of oral prednisolone, and these patients may require specialist treatment. If neither the FeNO level or the blood eosinophil count are raised, then we can consider a trial of either a leukotriene receptor antagonist, such as montelukast, or a long-acting muscarinic receptor antagonist, such as tiotropium, with a Spiriva Respimat inhaler, in addition to moderate dose MART, for 8 to 12 weeks, unless there are side effects. At the end of the trial, if asthma is controlled, we continue the treatment. If control has improved but is still inadequate, we should continue the treatment and start a trial of the other medicine, so either the leukotriene receptor antagonist or the long-acting muscarinic receptor antagonist. But if control has not improved, then we should stop the new medication and start a trial of the other medication that we haven't yet used, i.e. either the leukotriene receptor antagonist or the long-acting muscarinic receptor antagonist, alongside moderate dose MART. If asthma is still uncontrolled after these steps, then we should refer. Here it is worth recapping what constitutes uncontrolled asthma. It's any exacerbation which has required oral corticosteroids, or having frequent regular symptoms, such as needing to use a reliever inhaler 3 or more days a week, or having nighttime waking 1 or more times a week. It's also important to try and address any other possible reasons for uncontrolled asthma, such as suboptimal adherence to medication, suboptimal inhaler technique, smoking, or environmental factors, such as indoor mold exposure. It's also important to highlight that high-dose inhaled corticosteroids and theophylline are no longer featuring in the new treatment pathway. Also, that we are advised to refer patients with uncontrolled asthma who are using a high dose of an inhaled corticosteroid. With regards to montelukast, the new guideline prompts us to the drug safety update from the MHRA in 2024, where they state that healthcare professionals prescribing montelukast should be alert to the risk of neuropsychiatric reactions in all patients, including children and adolescents. Reported neuropsychiatric reactions include sleep disorders, hallucinations, anxiety and depression, as well as changes in behaviour and mood. Healthcare professionals should advise patients and their caregivers to be alert to these risks and seek medical advice as soon as possible if neuropsychiatric reactions occur. Also included in the latest guideline are ways that we can switch patients who have uncontrolled asthma and are on a previous treatment pathway to the new pathway. For example, we should consider changing treatment to a low-dose MART for people with asthma that is not controlled, who are using a regular low-dose inhaled corticosteroid with PRN SABA. After starting or adjusting any medication for asthma, we should review the response to treatment after 8 to 12 weeks. Now, as promised, it's time for the quiz. I have 4 questions for you, which are either true or false. Number 1, we can now potentially diagnose asthma with a blood test. True or false? The answer is true. You will now find yourselves constantly looking at eosinophil levels. Question 2. A 7-year-old patient comes to see you with symptoms suggestive of asthma. He has been under the allergy team for many years and has shown evidence of house dust mite sensitization on skin prick testing. This is enough to confirm an asthma diagnosis. True or false? The answer is true. Question 3. A patient with newly diagnosed asthma should be started on a low-dose inhaled corticosteroid and a separate reliever inhaler. The answer is false. They should be started on AIR therapy with a combination inhaler containing a low-dose corticosteroid and formoterol to be taken as needed. Or if they are highly symptomatic or have had severe exacerbations, low-dose MART. And finally, question 4. If a patient is using a moderate dose MART but still has uncontrolled asthma, then the next step is a trial of either a long-acting muscarinic receptor antagonist or a leukotriene receptor antagonist alongside the MART. True or false? The answer is false. The next step should be to check an FeNO level, if available, and a blood eosinophil count. And if neither of these tests are raised, then to consider a trial of a long-acting muscarinic receptor antagonist or a leukotriene receptor antagonist in addition to moderate dose MART. If either test is raised, then we are advised to refer the patient. How did you do? Thank you all for listening today. I hope that you found this podcast helpful and that you've learned a few extra nuggets of information and that you'll tune in again for part 2 of this podcast later in the year. As always, all of the links to the resources I've mentioned will be in the podcast show notes at GPnotebook.com. And we'd be very grateful if you would consider following the podcast and leaving us a review on your favourite podcast platform. Feel free to get in touch via social media at GPnotebook or email support@gpnotebook.com if you have any questions, comments or ideas for future podcasts. Right, I'm off to calculate the amplitude percentage mean for everything. Goodbye.